Good evening, everybody. Welcome to this evening episode of Pursue. And we are streaming live from Kolkata, and this is Pursue 1N, which is Uropathology. And we have a very interesting topic today, which is cystic and dysplastic lesions of kidney, which has two components, the benign and the neoplastic component. And we have a very, very proficient, very well-known pathologist, Dr. Mitadru De Sarkar, will be speaking on that. Dr. Sarkar is an MBBS from JIPMER, Pondicherry, and an MD from JIPMER, Pondicherry. He's a consultant Histo and Cytopathologist and the lab head with overall quality in charge at the famous Calcutta Heart Clinic Hospital, Kolkata. He was also the ex-assistant professor, Department of Pathology at the SMV Medical College and Hospital, and an ex-consultant pathologist at the SRL Diagnostics Fortis Hospital, Anandapur, Kolkata. Before I ask Dr. Sarkar to take over, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Sarkar, sir, please share your screen and let's start. Just press that central arrow, your entire screen. Yeah, fine.
Yes.
Just open your PowerPoint, please.
Is it sensor?
Just press that hide thing so that the pop-up goes in. Yeah, please start. Thank you so much.
Good evening, everyone. At the outset, I would like to thank Sir for having invited me to talk on this esteemed platform. This particular topic which has been given to me it actually sounds pretty innocuous, and it sounds as if there is just going to be a few cystic lesions and we can be done in a very short period of time. Unfortunately, this includes quite a few entities, a few of which do not really look cystic but are included within the rubric of this particular category. And dysplastic lesions of the kidney also to some extent fall within the cystic category. We shall see how. Firstly, we need to discuss about the basic formation of the cyst within the kidney. So the process of cystogenesis involves the aberrant formation or the maintenance of a cyst in a normally non-cystic structure like the kidney, which is normally seen in approximately 10% of the population. Most of the cysts will arise from the tubules, but some cysts can also arise from the region of the glomerulus. The cysts can be in the cortex, they can be in the medulla, or they can involve both the cortex as well as the medulla. They can involve one kidney or both. They can be diffuse or focal in pattern. They can be randomly distributed or sometimes distributed along a specific distribution, like for example along the course of the corticomedullary junction. There is no universally accepted classification scheme. Different textbooks try different approaches. Some talk about the genes on cilia, some talk about the tubular versus the glomerular localization, cortical versus medullary location of the cysts. For the purpose of the PGs, my first introduction to the topic of cystic kidney diseases was when we had been given in our gross seminar one of the cases of cystic dysplasia of the kidney. So basically, we had started off our discussion of cystic kidney diseases in our PG period based upon the location. Is it cortex, is it medullary, or is it diffuse? I think for the purpose of the PGs, that would be a practical and pragmatic approach. Once you know about the different entities which kind of localize between the different compartments, you can go on further and talk about the various genes which are mutated and the various categories of the disease. So actually in your practice, you come across lots of conditions which look cystic within the kidney. However, not all of them are actually included in the traditional definition of the renal cystic diseases. So the characteristic renal cystic diseases are the ones which we have been already taught in MBBS period, that is Adp Kd, Arp Kd, nephronophthisis, etc. So that would come under the category of the medical renal cystic diseases. However, once you start practicing, you will come across entities which are neoplastic and which look pretty much cystic, although a practicing pathologist will know that it's pretty easy to differentiate the two categories because these are circumscribed and form an SOL, whereas the others are often they do not form a single cohesive mass. But still, since these are also cystic, we will have to talk about them along the course of the discussion. Since this lecture is aimed towards the PGs, I have taken some time off to talk a little bit about the two important textbooks in our PG curriculum and the focus on the cystic diseases which is given on these two textbooks. So if you look at Rosai and Ackerman, The cystic diseases of the kidney is given kind of short shift. He, I think, finishes it off within 6 to 7 pages, and the entities which are included are quite a few. So you have got the renal dysplasia, you have got Adp Kd, ARP Kd, nephronophthisis, autosomal dominant tubulointerstitial kidney disease, which was priorly called medullary cystic disease of the kidney, medullary sponge kidney, acquired cystic diseases, and simple cysts. This sounds pretty simplistic. So I actually prefer the approach which is given in Sternberg. I am a bit biased towards Sternberg because in a few categories it actually talks a bit more than what is given in Ackerman. So if you see the approach given over there, most of the entities tally. However, you come across this entity called multilocular renal cysts. So, and if you look at the standard textbooks as well as the literature available now, you won't find this particular entity. But if you do a literature search through Google, you will come across entities like cystic nephroma and cystic partially differentiated nephroblastoma, both of which are actually tumoral entities. So we see that Sternberg has actually also included the tumoral category within the classification of the renal cystic disease. This is actually the approach which is even given in the standard Uropath texts. So as per Bostwick, so I have actually gone by the approach which is given in Bostwick. So he talks about the non-neoplastic cystic renal diseases, in which we talk about autosomal dominant polycystic kidney disease, recessive polycystic kidney disease, the tubulointerstitial syndromes, which are sometimes cystic but often not. So in this particular category, we have got the autosomal dominant tubulointerstitial disease, which was priorly called MCKD, and nephronophthisis. Renal dysplasia can sometimes be cystic, however, it can often be non-cystic as well, just presenting as a kind of aplasia. Glomerulocystic disease is most often it is a secondary change, which is usually seen in the case of other cystic entities, for example, ADPKD, ARPKD, etc. Sometimes it can be primary and syndromic as well. Then there is another category of non-neoplastic renal cysts, which are, however, associated with two important tumoral syndromes. These are tuberous sclerosis and von Hip and Lindow disease. And this ischemic atrophy of this glomerulus is another important cause, as well as acquired cystic kidney disease. Aside of that, there are a few miscellaneous cysts like simple cortical cysts, medullary sponge kidney, etc. Talking about the cystic renal neoplasms, we can actually segregate this into two categories. First in the children and then in the adults. So in the children, you have got two important categories, pediatric cystic nephroma and cystic partially differentiated nephroblastoma. Whereas in the adults, the entities which are included are the ones which have actually just of late come into the WHO lexicon over the last 4 or 5 years. Some of them are pretty old, cystic nephroma, and you have got the mixed epithelial stromal tumor, which is actually a part of the same family. You have got this new entity known as the multilocular cystic renal neoplasm of the low malignant potential, cystic clear cell renal cell carcinoma, tubulocystic carcinoma, and clear cell papillary renal cell carcinoma. So as discussed with sir, we will today talk only about the non-neoplastic renal diseases, and in a future session carry on about the cystic neoplasms of the kidney. So talking now about the non-neoplastic pathologies, the first category of the non-neoplastic entities which gives rise to a cystic appearance are called the renal siliopathies. So these are basically secondary to the mutations which happen within the primary cilium of the renal tubular cells. Mostly they can be inherited in an ADI fashion or in an ARI fashion. So you have got autosomal dominant polycystic kidney disease or autosomal recessive polycystic kidney disease. But also nephronophthisis comes into this particular category. Nephronophthisis is often sporadic but can be syndromic in association with syndromes like Bardet-Biedl syndrome, Joubert syndrome, etc. But first let's talk about this primary cilia, because whenever we speak of cilia, the first image that it conjures up is that of a motile cilia, which is usually present in the respiratory epithelium, spermatozoa, etc. These usually have a 9+2 structure with a central pair of microtubules, and they also have dynein arms. These are usually associated with entities like primary ciliary dyskinesia, Cartagena syndrome, etc., as we have already read. The primary sensory cilia, however, do not have the function of motility. On the other hand, they are actually important for sensing the hormones and the growth factors in the ECF, following which there is a signal transduction downstream, as a result of which the most important role of this of this particular cilia is during the process of mitosis. When they help in maintaining the plane of the cells, they also regulate proliferation of the cell and apoptosis. These are essential for left to right orientation, along with sensation in the renal tubules as well as the biliary epithelium, photosensing as in the retinal pigmented epithelium, and chemosensing as in the olfactory neurons. The structure is slightly different, as in they don't have this central pair of tubules. They also do not have the dynein arms because they don't need to move basically. The functional defects are those which will give rise to the ciliopathies. So this particular article has shown the various distribution of the proteins along the course of the primary cilium, and as you see, polycystin 1 locates to the membrane, 2 both in the membrane as well as in the basal body. Fibrocystin, which is a pretty large protein, mostly is seen in the basal body but also in the axoneme, and inversin also in the axoneme, as well as nephrocystin, which is present in the axoneme as well as in the transition zone. The importance of going through this particular names of these proteins is that quite a few of them tend to be mutated in the primary ciliary protein deficiency diseases. Thus, polycystin 1 and polycystin 2 are mutated in Adp Kd 1 and 2 respectively. Fibrocystin polydactin is mutated in ARPKD. Inversin and nephrocystin are associated, most importantly, NPHP1 is associated with nephronophthisis 1 category. So, in short, the system of action of the primary cilia would be, you have extracellular growth signals which activate these proteins. There is a downstream activation of the pathways, most importantly the sonic hedgehog pathway, ultimately resulting in its activity, that is to maintain the polarity of the cells as well as to regulate the proliferation of the cells. So if there is a mutation of this primary ciliary genes, this particular function will be lost. So this might happen within the uterus, in which case there will be a severe disease phenotype, whereas in the post-developmental, post-growth phase, there will be a mild disease phenotype with a late onset. So most of the ciliopathies will actually have diverse kind of presentation, some of which will overlap with the others. This particular syndromic one actually shows the range of organs which can be involved in this particular disease. So there can be retinal degeneration because, as I have said, primary cilia are often are seen in the retina. You also have cleft lip palate, hepatic cysts because they are also expressed in the bile ducts, genitourinary malformations, situs inversus because they are essential for left to right orientation, polydactyly. You also have underdevelopment of the cerebellar vermis along with the molar tooth sign, in which basically the interpeduncular fossa is kind of depressed, giving rise to the appearance of that of a molar tooth. Most importantly, in many of these conditions, we have renal cystic disease. So let's straight away go to the first entity, which is autosomal dominant polycystic kidney disease. As we have already read, it's associated with mutations in the polycystin genes, in which PKD1 mutation is commoner than PKD2. More important is the fact that PKD2 mutations will have a lesser severity disease and a later age of onset, and the changes which are seen in the kidney might not be the same as you see in the case of autosomal dominant polycystic kidney disease due to PKD1 mutations. So the ADPKD1 usually presents at the age of 30 years with hypertension, renal failure, hematuria, mitral valve prolapse, frank pain, etc. And around 50% of these patients will need dialysis by 50 to 60 years of age. Also, around by the age of 50 years, the patient starts to develop hepatic cysts. So these hepatic cysts, which are actually not very fatal. Cysts also develop in organs like the pancreas, seminal vesicles, and the pineal gland. And also there is this deadly risk of formation of aneurysms within the circle of Willis, giving rise to subarachnoid hemorrhage. So grossly, these particular kidneys are enlarged to huge grotesque sizes. You have these cysts which are seen to pop out both on the external surface and also internally. So you have these thin-walled sac-like cysts present all over the renal surface from the external aspect. So let's talk a little bit about the pathomechanism of this particular disease. The first hit, so this happens because of LOH, so loss of heterozygosity. The first hit happens within the germline when the first copy of the PKD is mutated. Later on in life, the second copy, that is, it is also mutated, resulting in a somatic mutation, because of which once there is a 2 hit, there is unopposed action of the external growth factors, resulting in uncontrolled proliferation of the tubular cells, resulting in outpouching of these tubules. Subsequently, these tubules get detached from the parent tubules, and because of the cyclic AMP mediated pathways, there is increased accumulation of salt and water within these particular cystic structures, resulting in the formation of cysts. So this is the external appearance. A small kidney has been shown by the side to show the kind of massive enlargement that these kidneys can show. Once you section the kidney, so this particular kidney has been bivalved, you see that the cortex as well as the medulla are effaced by multiple cysts of varying size, starting from very small to extensively large ones. The pelvic alysial fat is seen here towards the middle. This is another picture of an advanced stage disease where you see some amount of fibrotic thickening in the wall of the septum, and this is the microscopic picture of the same. So let's see a virtual case of this particular disease. As you see, the cysts are of varying sizes and seem to efface both the cortex as well as the medulla. So once you go into it at a higher power, you see that the parenchyma between these cysts actually looks pretty busy. It looks blue because there is a lot of inflammation happening within this parenchyma. So tubulointerstitial, there is a bit of interstitial inflammation, scarring, tubular atrophy, etc., which happens towards the late stage of the disease. These cysts are of varying sizes, as I said, they are small to large. They are often lined by a layer of flat cuboidal cells, but one thing that is very striking in this particular disease is that you have sometimes papillary hyperplasia emanating from the wall of the cysts. So if you see at a higher power, lower down, you have the cuboidal epithelium which is lining the cyst, whereas above you have these papillary hyperplastic folds which are emanating within the cyst lumen. And you also see the interstitial inflammation and some amount of fibrosis which is happening. So this particular glomerulus looks relatively untouched, while we have a free-floating papilla within the lumen of the cyst. So that's all about the microscopic findings in this particular disease. You have a diffuse obliteration of both the cortex as well as the medulla. The most important thing is that the cysts here can arise from any of the nephron segments, although the most common site of involvement is the collecting duct and the PCT, proximal tubule. Single layer of epithelium, sometimes with papillary hyperplasia, and the adjacent parenchyma will show interstitial inflammation, fibrosis, tubular atrophy, glomerular sclerosis, etc. as a secondary change during the later stages of the disease. So how do you go around diagnosing Adp Kd? So basically the diagnosis of Adp Kd is especially important if you know that a family has a patient and there is a younger donor who would like to donate, but then they want to know whether they also have Adp Kd. So the tried and tested method is the particular USG procedure that we know, that is called the Rabine's criteria. As you see in this particular criteria, they have segregated the patients into three groups: less than 30 years, 30 to 59 years, and more than 60 years. The concept is that the higher up you go in age, the more are the normal number of cysts that are seen. So basically in a higher age group, you expect to see more number of cysts. As a result, if there is no family history, you need to have at least 8 cysts in each kidney. On the other hand, if you have a positive family history, that particular requirement can be brought down to 3. In the case of less than 30 years, you would have to have at least 5 cysts, but because renal cysts are not really that common in that age group, so our laxity, our diagnostic criteria is slightly lax, because we are allowing for the cyst to be formed in one or both the kidneys. However, if there is a positive family history, at least 2 is enough. Now this particular procedure, this particular protocol sounds pretty good and elegant. In fact, it's pretty good at diagnosing these last 2 categories, where it has almost 100% sensitivity rate. But if you look at the less than 30-year-old age group, many of whom will actually have the PKD2 mutation, and that does not usually present as the traditional Adp Kd like large cystic disease. So the sensitivity comes down to 67%. You have got more sensitive USG scan protocols like the Dimitru and the PACE protocol, the scope of which is actually beyond the course of my discussion. You can do an MRI or CT scan, which is actually much more sensitive, and nowadays you can go in for a PKD1 and PKD2 screening. So PKD2 screening along with some of the other ciliopathy associated genes by the platform of next generation gene sequencing. Coming now to ARPKD. So as we saw, ADPKD was a disease which has segregated in the usually older age group, starting from the 30s. However, ARPKD is something which is more often seen in the younger age group. So this particular ciliopathy is due to mutation of the polyductin and the fibrocystin protein in a ARI pattern. There are actually three forms, most importantly two. There is one lethal neonatal form which we have all come to know during the course of our MBBS, where you get the characteristic Potter fasces along with the bilateral huge enlarged cystic kidneys along with the small lungs. However, there is an infantile form, and the infantile form is the one which will cause the biggest problem, because by the time the patient presents with an infantile ARPKD, the seat of the action has actually shifted from the cortex medulla to inside the medulla. So the cysts are now few in number. They are only located within the region of the medulla, and actually the seat of action has moved to the liver, where you are getting the entity known as congenital hepatic fibrosis, which will subsequently give rise to portal hypertension as well as ascending cholangitis. Anyway, in the case of the lethal neonatal form, the kidney which has been shown towards the right is the one which is associated with the lethal neonatal form. They are massively enlarged, grotesquely large kidneys with a spongy cut surface. Spongy because the cysts here are usually not that large as you see in the case of ADPKD. They are usually less than 2 cm, usually around 1 cm in size, and they have got a characteristic radiating cylindrical pattern which might not be appreciable here. I have got a better picture subsequently. So let's talk about the phenotype. So in the classic infantile form, which is often incompatible with life, you have got the characteristic Potter fasces. So you have got increased distance between the eyes, prominent infraorbital creases, flattened nasal bridge along with the flattened tip, low set pinny, and small mouth, micronathia. This is associated with reduced amniotic fluid volume, grotesquely enlarged kidneys, and hypoplastic lungs. And as you see in this particular liver, there is this small yellowish white nodules which are present over the surface. So early portal fibrosis has actually set in, which if it was allowed to have some more time would have led to a full-blown nodular appearance within the liver. So this is actually how the cut surface of this particular kidneys look. As you see, this got a pretty beautiful symmetric kind of a pattern involving both the cortex as well as the medulla. The cysts start off from the region of the medulla and then emanate in a perpendicular direction towards the cortical surface, giving rise to a spongy appearance. And they are all very small in size. So this particular virtual case shows us how the cysts should look. So basically they are a kind of reflection of what we saw in the gross. The cysts are actually, they arise from the collecting ducts, from the region of the medulla growing up towards the cortex. They are elongated, cylindrical, circular, and you see that the intervening nephrons appear to be normal. We shall see subsequently at a higher power. So you see all these circular, cylindrical, elongated cysts emanating at a 90-degree angle towards the cortical surface. The intervening parenchyma shows unremarkable tubules as well as normal glomeruli. So these tubules are normal, whereas you also have these circular, elongated, dilated tubules of ARPKD. Normal glomeruli are also seen in this picture. There is a little bit of interstitial inflammation happening. So the PCT appears to be normal, whereas you have got an elongated collecting duct towards the left hand of the picture, left side. The cysts are lined by bland, low cuboidal epithelium, and that is how they look, basically. So it's pretty simple actually. Once you have the gross and the microscopy and the age group as well as the phenotype in mind, the appearance is pretty simple. But as I said, the main problem will not happen in the neonatal ARPKD. It's pretty much classic. But if you get such a patient in the infantile period, that's when the problem happens, because your cysts are now gone and localized into the region of the medulla, and that particular area is a pretty complicated one, because as we see, some of the entities lower down in a course of our discussion actually localized towards the region of the medulla, and there are now only a few in number, and there is a lot of tubulointerstitial inflammatory scarring now going on. So if you see, this particular one has been taken off a textbook. So here the cysts are actually seen only in the region of the medulla. As you see, the bulk of the cysts are happening towards the inner aspect of the kidney. And the size of the kidney also is not as grotesquely enlarged as we saw in the case of the usual neonatal form of ARPKD. So as I said, the main activity is now actually happening within the liver. So you see this enlarged fibrotic septae which are running all over the surface of this liver. And if you saw a microscopic section, we have got a better slide actually to see what happens about around here. So you have got this biliary ductal plate malformation happening at the same time. So we need to talk a little bit about the embryologic development of the ductal plate, which is again dependent upon the primary ciliary genes. So basically in the embryonic stage, you have this ductal plate, which is basically a thin epithelial sleeve of around 1 to 2 cell thickness happening in the mesenchyme around the portal vein branches. This could give rise to both the liver cells as well as the bile duct lining epithelial cells. Subsequently, there is a duplication of this plate and formation of primitive bile duct lumens. This subsequently gives rise to what we call the in utero remodeling within this particular ductal plate, and this happens throughout the biliary tree, starting from the region of the hilum outside, from the region of the hepatic ducts, going inside towards the segmental ducts, interlobular ducts, and finally trickling down to the smallest bile duct branches. If there is a normal remodeling, you have a normal bile duct, whereas with abnormalities because of the primary ciliary gene mutations, you have involution which is happening in an abnormal fashion, resulting in multiple cystic defects along the biliary tree. So this is a pretty famous book, Sherlock's. So I just moved on to that book just to show you the range of diverse appearance of the liver cysts that you can see in association with this primary ciliary gene mutation. So basically you could have a cystic change happening along the biliary tree. Choledochal cyst, if it is externally, and towards the internal hepatic ducts, if there is a dilatation, you have a Caroli disease. If it is associated with congenital hepatic fibrosis, you have what is known as the Caroli syndrome. And you also get polycystic liver disease, which is seen in Adp Kd and not in Arp Kd. So basically, if you look at the ductal plate malformations, you see that they can involve any of the biliary duct tracts, starting from the large bile ducts outside the liver and going into the smallest level of the bile ducts. So you can have all these diseases. Polycystic liver disease and biliary hematomas will be seen in Adp Kd, whereas congenital hepatic fibrosis is seen in Arp Kd. So this is how the cut surface of a well-formed congenital hepatic fibrosis would look. It gives a kind of an appearance of a micronodular cirrhosis of the liver, because the liver parenchyma is actually kind of split up into these small nodules because of the portal fibrotic expansion. As you see, these are the islands, these are the nodules of the hepatocytes, which are ruined by these grotesque caricatures of the biliary ducts which are present around the interface between the stroma and the hepatocytes. Okay, so basically you have a marked fibrous portal tract expansion along with numerous ectatic irregularly shaped bile ducts at the interface. There is no significant inflammation and portal veins are often reduced in number. So what is the role of USG or say for that matter CT MRI in Arp Kd? The role in Arp Kd is not as well defined, although it is very important. There is a bit of a problem with Arp Kd because we are actually looking at the neonatal age group, and sometimes appreciating the small sub-centimeter cysts, less than 1 centimeter size cysts with a conventional USG might not be very easy. To this is added the problem that around 1% of the cases of Adp Kd can actually present within the neonatal age group as well. Plus you have this particular entity of nephronophthisis, which can actually sometimes go into that particular age group, and these cysts are actually not that easy to differentiate on a conventional USG. However, if you use a 75 Hz transducer, that is the high resolution USG, allows us to see those characteristic cylindrical cysts extending from the region of the medulla into the cortex, and they are pretty good for that purpose. If you do not have access to that, you could try a high sensitive procedure like CT or an MRI scan. Initially the cysts look a bit hypoechoic, whereas later on the echogenicity increases subsequently. However, you see that because of the slight reduction in sensitivity of these imaging procedures, there is a definite role for molecular diagnostics. So you could do a mutation based diagnosis by either Sanger sequencing of the single gene, that is the PKHD1 gene. So a small tidbit about this particular gene: this is one of the biggest genes, the biggest gene sequences that is known in the human body. So actually the problem with this kind of a big gene is that there are actually multiple polymorphisms that can happen in this gene, and sometimes we don't know the significance of those polymorphisms. Some of those might not be actually associated with ARPKD. Okay, and plus you also get sometimes missense mutations which might not have clinical significance. So interpreting those particular genetic mutations in the context of a big gene sometimes becomes problematic. But because your cystic diseases in this particular age group will include just not ARPKD, as I've said, there are also some of the other cystic diseases to be thought of. Rather than Sanger sequencing, the approach now is to go in for a next generation gene sequencing wherein you factor in the possibility of a neonatal ADPKD along with nephronophthisis plus ARPKD. Now coming to the third entity, that is nephronophthisis. So basically now we are moving away from the traditional appearance of large grotesquely enlarged kidneys with multiple cysts throughout. We are actually now talking about kidneys which might be normal or even sometimes smaller in size, and the cysts and the cystic change will actually be only a kind of a secondary change. Sometimes it might not be seen at all. So nephronophthisis, which in my MBBS days was called as juvenile nephronophthisis, we now know that it actually segregates into multiple age groups. So you can have an infantile form, you can have a juvenile form, and an adolescent form. So it is also inherited in an autosomal recessive fashion. The most important gene is NPHP1, but there are lots of genes basically now talked about. I have not included them because I would like to keep this particular discussion crisp and focus towards one particular point. But you can see there are multiple genes which are given in the text, and sometimes you don't even find any specific gene mutation after doing the usual workup for the genetic analysis. The most important change, this particular disease is actually included within the tubulointerstitial disease category, meaning that the most important change will happen in the interstitium in the form of interstitial inflammation, fibrosis. There will be tubular atrophy, dilatation, and that dilatation might sometimes give rise to a microcystic appearance, which will be specifically along the corticomedullary junction, as we can see from this particular case. In fact, if you are not aware of the particular entity and know that this goes into the cystic family of diseases, you might actually ignore them sometimes. So you have got three important categories: type 1, type 2 and type 3, that is the infantile, juvenile and the adolescent forms. The type 1, however, can show some amount of phenotypic overlap with the ARPKD, so that should be kept in mind. That is the one which will sometimes cause problem when you do a conventional USG scan. And the type 2 is the one we had been always taught, that is the kind of juvenile one that happens at approximately 13-year age group, whereas the slightly older type 3 form presents at around 19 years of age. Most of those diseases usually present in the less than 30-year-old age group. The primary defect here seems to be in the thick ascending limb of Henle, and as we know, sodium potassium 2 chloride reabsorption is the most important thing happening there, and because you don't have sodium reabsorption happening properly, you have polyuria along with polydipsia and end-stage renal disease. And this particular type of end-stage renal disease is pretty interesting because you don't have the other markers which are usually seen in the case of a conventional chronic renal failure. Like for example, you don't have a very active urinary sediment, you don't have proteinuria, you don't have hematuria. So basically the urine sediment is pretty much bland. However, the patient is slowly progressing into a stage of CRF, ultimately going into ESRD. Good number of these cases will be associated with syndromes, like for example retinitis pigmentosa, etc. We'll be talking about this particular syndromic form subsequently. So what about the gross appearance? As I've said, the large multicystic kidneys will be seen only in the infantile form, whereas when you talk about the type 2 and the type 3, they will actually present with normal or sometimes even small appearance of granular contracted kidney. And when you cut it up, you see that there are sometimes these small cysts within the corticomedullary junction. As you see, this particular picture shows this nice cyst which is actually located only around the corticomedullary junction interface. So this USG shows the same localization of these zones with low echo. As you see, the corticomedullary junction is showing this characteristic cyst, and microscopically you are seeing a whole lot of activity happening in the interstitium. It's very busy, it's very blue, meaning that there is a lot of interstitial inflammation, fibrosis along with tubular atrophy and cystic dilatation. There are also changes happening in the glomerulus in the form of periglomerular fibrosis, concentric fibrosis. So that's basically what you will get in the microscopic section. You will get a lot of interstitial chronic inflammation. So this particular disease is a tubulo-interstitial disease. You're getting the interstitial inflammation along with the tubular changes in the form of atrophy, dilatation, and subsequent change in the form of cystic change, especially along the corticomedullary junction interface. Something happens to these particular tubules. They get distorted, they get damaged, and uromodulin, that is our famous TAM horsefall protein, escapes into the interstitium, and now you have IHC that can pick up this particular protein. So this shows the picture that you get. Another important thing that you get over here is that the tubules, the basement membrane around the tubules, which is usually one layer only, becomes multiple, often two or more, giving rise to a multilayering of the tubular basement membrane and an appearance of an apparent splitting of the tubular basement membrane. I don't know whether it can be appreciable in this particular picture or not, but if you see these tubules, you can see these two black lines which are seen in the Jones methenamine silver staining. So the black lines are basically the argyrophilic basement membrane which is picking up this positivity, and two lines means that there is a duplication of the glomerular basement membrane. So there is a basement membrane multi-layering. And as I said, interstitial inflammation along with tubular atrophy, glomerulosclerosis, often in a concentric fashion. These are all seen in this particular disease. The secondary cystic dilatation is of the tubules, which is especially only seen along the corticomedullary junction. And there can be a secondary cystic dilatation of the glomeruli also happening later on in the course of the disease. And as I said, IHC. So basically this IHC, it looks red because you have used a fast rate counter stain instead of the usual Dept reagent. So basically you see all these pools of leaked uromodulin which has escaped into the interstitium from these dilated cystic tubules. So there are a whole lot of these syndromes which are associated with this particular disease. I will not bore you with the details of all these particular syndromes, but a particular pattern comes to mind. For example, cerebellar and CNS involvement is common in many of these categories. You also sometimes have portal fibrosis, as in the case of Meckel-Gruber syndrome. Renal cystic dysplasia, which is also included in the course of my discussion, also sometimes has an overlap in the sense that this particular syndrome can have both. It can have nephronophthisis and also cystic dysplasia. And retinal involvement seems to be pretty common across most of these categories because, as I have already said, the primary cilium is expressed in the retina as well. And another very important thing that we see is that along the spectrum of these particular syndromes, renal cystic disease happens to be pretty common. So the syndromic forms of this NPHP will be usually associated with the renal cystic change. So we are finished with the various ciliopathies. So let's just in a short slide talk a little bit about the problems that we have with these particular categories. First is Adp Kd. Although the image that is immediately conjured up is that of a grotesquely enlarged large kidney with multiple cysts, that is the usual case that you see in the case of PKD1 mutation, where the disease will happen early and progress to ESRD faster. However, if you have a PKD2 mutation patient, you might not be so lucky and you might get a kidney which is smaller in size with not so many cysts. So basically there you have a role of genetic sequencing. ARPKD, again, if it's the lethal neonatal form, you would expect to see the classic textbook picture, but if you are getting the patient in the post-neonatal period, you will get mostly medullary cysts and actually you will have to look towards the liver. And as I said, the genetic mutation is also fraught with some problems because within the same family, the different members might not be sharing the same mutation of the genes. There might be private mutations which are seen only in one particular patient within this particular family. And as I said, because some of those gene sequences are very large, you can have polymorphisms which are of doubtful significance. Having said that, the NGS platform has achieved a good kind of sensitivity in that in the case of ADPKD, more than 90% of the cases will get detected. It's around 85 to 90% in the case of ARPKD, I believe. In the case of nephronophthisis, infantile form can show an overlap with the ARPKD. Although, if you see the histology, of course, you know that the picture will be totally different from what you see in the case of ARPKD, and you have also got molecular diagnostic protocols. The juvenile form is the one which will be characteristically associated with the tubulointerstitial disease, and that overlaps with the next topic of our discussion, that is autosomal dominant tubulointerstitial kidney disease, which was priorly called medullary cystic disease of the kidney. So on to the ADTKD category, that is MCKD. So basically, autosomal dominant tubulointerstitial kidney disease is associated with 4 main categories of mutations. So you have got mutation of the uromodulin gene, NUC1, that is the EMA, renin gene, and hepatocyte nuclear factor 1 beta gene mutation. The net result is again a tubulointerstitial disease with tubular atrophy, tubular death, nephron loss, and in some cases formation of dilated cystic like this dilated cyst from those tubules. And again, just like in the case of nephronophthisis, you have this cyst located specifically in the region of the corticomedullary junction. So there is a lot of gross overlap. Plus, the kidney is often normal size or sometimes even small, as in a granular contracted kidney. And the site of the hit of the nephron is the same. So basically, you have the same kind of clinical presentation that you see in the case of other tubulointerstitial diseases. You have polyuria, polydipsia, which if you are getting the history in a very small kid, would be highly suspicious of this particular category of diseases. Leading on to ESRD, usually the end stage renal disease here happens in a slightly older age group. So that's one important thing to keep in mind. So if you are seeing this particular ESRD due to a tubulointerstitial disease in the less than 30-year age group, more chances of it being a nephronophthisis. Although there are a few categories of this ADTKD which can also present in a lower age group, as we will see subsequently. But overall, this particular category usually presents in the above more than 40-year age group. Another very important finding that we see in this group of diseases, not in all, but if it is present, it is very important, is that uric acid levels are elevated. This is especially seen in the case of UROM mutations. And you get an early onset gout, often in the case of children as well. So the kidneys can be large if cysts are many, but more often they will be normal or sometimes even small in size, and you will get the cysts in the corticomedullary junction. The presence of this cyst is not essential for diagnosis, which is why I had said that some of those entities might not be cystic at all. So what is the pathomechanism? The pathomechanism we can think of is as basically misfolded and unfolded proteins, which are all deposited within the tubules, and because of these abnormally deposited proteins, the tubules undergo subsequent destruction, loss, atrophy, resulting in subsequent inflammation along with cystic dilatation. So in the case of UMOD mutation, you have misfolded uromodulin protein which accumulates within the tubular epithelial cells in sites like the ascending limb of the renal and as well as the first part of the DCT. In the case of renin gene mutation, you have got the pre-pro-renin precursor, which is basically unfolded and abnormal and accumulates in the cells of the JG apparatus. In the case of the MUC1 mutations, you have this altered MUC1 protein known as MUC1-FS, which accumulates in the DCT, collecting duct, and in the thick ascending limb of the loop of Henle. HNF1B gene mutation, however, is not that easy to explain. I have seen a few sources, they were not actually able to come up with a satisfactory explanation. It is suggested that aberrant transforming growth factor beta pathway signaling could lead to fibrosis, but it does not explain the tubular changes basically. Whatever it is, and as you see, there is a lot of misfolding and unfolding going on. So basically, it is logical that you will have IHC to pick up these misfolded proteins. I'm not really sure whether it's available in the practical purpose, in the sense that whether most of the non-academic institutes do it. I don't think so, but I guess academic institutes which are into this kind of diseases will be doing this kind of IHCs for UMOD or, for example, MUC1-FS. The net change is a chronic interstitial nephritis along with interstitial fibrosis, tubular atrophy, and cystic tubular dilatation. So, as I said, the pathology is pretty simple. It's almost the same that you see in the case of NPHP, except that there are specific diagnostic features which need to be considered. So, in the case of uromodulin mutation, you have these cytoplasmic UMOD deposits which can be picked up by IHC. In the case of renin mutation, you have IHC for renin, which basically shows no staining. So basically the lack of staining there would kind of be diagnostic. But renin and MUC1 mutations are also often associated with the one that I had already shown priorly, basement membrane thickening along with duplication as well as disruption. HNF1B mutation is associated with a primary glomerulocystic change, which we'll be subsequently talking about when we come into the category of glomerulocystic disease. MUC1 mutation, as I said, the mutant MUC1-FS can be detected by IHC. So, tubulointerstitial fibrosis, so the overall appearance is that of a chronic interstitial nephritis and cysts sometimes, especially around the corticomedullary junction. So, this particular slide shows the entire So this I guess is a PA stain slide because it gives a kind of a magenta kind of a hue. So you have got this lot of tubulointerstitial inflammation along with kind small amount of atrophic tubules which look kind of dilated. This particular slide shows the whole lot of changes that you can see. So basically a PAS stain shows that in some cases the basement membrane appears to be slightly thickened, and you also have the cystic dilatation of some of these tubules, and these are seen as low echo zones in the corticomedullary junction interface on USG. So this particular slide shows the whole lot of changes that you can see in this particular disease. Moving on to the more specific subcategorization within this particular disease, if you were to look into some of these tubules, so these things, unfortunately I was not able to get any cases for this particular thing, so I have just picked up some ones from the standard text, reference text. So you have this fibrillar kind of appearance within the cytoplasm, which is basically the misfolded UMOD proteins in the case of UMOD mutations. And if you do a Mason trichrome, so this particular slide shows things nicely. For the purpose of PGs, you have a single slide showing almost the entire range of changes that you can expect to see with a normal Mason trichrome. So you have got the collagen, which is blue, you have got the RBCs, which is red, and then you have got these inclusions which are also staining a kind of slightly purplish red in color. And of course, to be much more specific, you will have to do the IHC for this UMOD, which is seen as the positivity of brown within the cytoplasm for this abnormal protein. As I said, in the case of renin mutations, you will get a tubular basement membrane thickening, multi-layered appearance. So you have a bilayering along with an appearance of the split of the basement membrane. Glomerular cystic change could happen in the case of HNF1B mutation. So as you see, all of these dilated structures are not tubules. These are basically dilated glomeruli with the small glomerular tufts as a small nubbin towards one of the poles. So for the purpose of PGs, basically I have just made this single slide which kind of puts all the four categories of this ADTKD family into a single perspective. As you see, they have the common feature of being chronic tubulointerstitial nephritis, sometimes with a cystic change. Gout may be seen in some of these cases, and especially early onset gout will be common with UMOD mutations. The age of onset usually happens in the above 40-year age group. However, renin mutations can sometimes present in childhood as well. Renal cysts will be seen in many of these cases. However, keep in mind that renin gene mutations will not usually have the renal cysts. As far as the IHC is concerned, I have already talked about it. In the case of HNF1B, we don't have IHC. However, an important clue is that there could be other kind of congenital anomalies along the course of the kidney and the urinary tract. So that might be looked into. Plus, the pancreas is usually underdeveloped in the case of HNF1B mutation. No such disease association is seen in the case of the other three. So how do you go around diagnosing these cases of ADTKD? The first thing would be the clinical suspicion. So of course you take a family history, and these cases sometimes have got 100% penetrance, so you can actually follow the proper Mendelian decision tree. So the history is that of an autosomal dominant pattern of inheritance along with the progressive loss of kidney function. So the history will be subtle, but there will be slow onset chronic renal failure setting in with a bland urinary sediment. Like I said, there will not be too many cells within the urine. There will not be much of protein loss in the urine. There will not be too much of RBC in the urine. However, there will be salt wasting and a slow loss in function of the kidney. However, keep in mind that tubulointerstitial nephritis category that this particular disease belongs to, pathologically speaking, the first thing that you should look for is not this category of diseases, it should be drug exposure. So you will have to exclude the history of any kind of drug exposure which can potentiate this particular pathology. As far as USG is concerned, most of the times, unless it's in the infants, the kidney will be normal or even the granular contracted kidney. And you will have the history of nocturia and sometimes gout if you have got a UMOD mutation. The finding on histology is the usual one that I've said, tubulointerstitial inflammatory disease. You will, however, have to subject the biopsy to immunofluorescence for complement immunoglobulins because you would like to exclude some of those autoimmune disorders as well along the course of the way. And finally, the genetic testing is available. I am not sure about the Indian experience, but the Western text that I have referred to talk about NGS platform which is utilized, and they have got robust NGS platform which can actually detect the mutations in UMOD, REN and HNF1B. However, the MUC1 genetic testing remains challenging. And why it remains challenging? I'll be showing subsequently. But the importance of the fact is that in the Indian context probably, and if you are talking about small hospitals which don't have recourse to this kind of costly procedures, you can still establish this particular diagnosis if there is a positive family history, if you have got compatible clinical and histological findings, and if you have got a kidney biopsy in at least one of the family within that, at least one of the individuals within that particular family. Now, the reason why the MUC1 genetic testing remains challenging is given in this nice article. So let's just look at the MUC1. So the issue is that the insertion is just of a single base pair. It's a single cytosine insertion, and unfortunately the point of insertion is not the same in all the families. So you cannot run a one-size-fits-all approach for all the families. They will be different. And unfortunately the area within which it is located is within the region of the variable nucleotide tandem repeats. So it's just alternating CG sequences, and within that you have got multiple sites where this abnormal cytosine can be inserted. It's not very easy to pick up on an NGS platform, which is why for MUC1, the NGS platform is still not that much standardized. Now, again, for the purpose of the PGs, let's have a single slide where we compare the two diseases, that is NPHP and ADT Kd, which more often are actually tubulointerstitial diseases with a small contracted kidney rather than a cystic disease. So you have a tubulointerstitial disease along with a small or normal sized kidney in both the categories. The only two exceptions would be an infantile NPHP where you have an enlarged cystic kidney, and a renin ADT Kd where you will usually not get too many of the cysts. Inheritance pattern in case of NPHP is ARI, in the case of this is obviously ADI. You will look for the syndromic associations that you will often see in the case of NPHP, which will not be seen in the case of this particular disease. You might, however, sometimes get a history of an early gout, which is clinically relevant. Median age is usually under the 30-year age group in the case of NPHP, whereas in the case of autosomal dominant tubulointerstitial kidney disease, it usually goes into a higher age group, except for the renin category. Now, the next discussion actually is a part of the topic which has been assigned to me by sir. So I have chosen to include this particular disorder along with the cystic diseases because quite often they will be multicystic, but the reason why I have actually highlighted this thing and put it in the bracket is that renal dysplasia need not always be multicystic. So, and for the purpose of the first year PGs, this particular dysplasia has got nothing to do with a pre-neoplastic potential, although sometimes they can give rise to Weems tumor, rarely. However, this particular dysplasia is actually in the context of an abnormally developed kidney with aberrant differentiation of the nephrons. Most of the time, it's usually seen in a sporadic fashion, but you can have familial patterns as well. It's a pretty common disorder and is the commonest cause of abdominal mass in the infancy and bilateral renal cystic disease in the newborns. One important thing to keep in mind is that if you have this dysplastic change happening in just one kidney, and there is no ureteric disease and the other kidney is absolutely normal, then chances are that many of these cases will ultimately undergo spontaneous involution. So some of those cases might go in for a wait and watch approach. However, most of the times you will find that these particular disorders are associated with some kind of disorder within the underlying ureter. There can be stenosis or dilatation along with significant amount of reflux. In fact, in many of these cases, this particular reflux is actually what is blamed for the dysplasia. And quite often the second kidney will also show abnormalities in the form of underdeveloped kidney, ectopy, fusion, and duplication of the ureters. So what happens, so this particular kidney where you have a dysplasia along with the duplication of the ureters is what we call the duplex kidney. So what happens is that so you have got two ureters basically draining the two poles. The first ureter is abnormally placed, as a result of which there is ureterocele, there is reflux, and subsequently there is a dysplasia within the upper pole. Subsequently what happens is that particular ureterocele goes and bulges and obstructs the lower ureter as well. So you have a hydronephrotic change happening within the lower pole. So those kidneys are more or less gone. Grossly, as you see, the kidneys, they can be multiple in appearance. They can be multicystic, they can be small to large, sometimes the cysts can be very large. So usually you get them in the case of the syndromic renal dysplasia, and sometimes they can be aplastic and non-cystic as well. Another important thing to keep in mind, although this particular picture shows the kidney maintains the normal bean-shaped appearance, however, often the kidney will lose that kind of appearance in the case of dysplasia. That usually does not happen in the case of polycystic kidney diseases. So as you see, this is slightly abnormally shaped kidney which has been bivalved, and it shows that the particular kidney, this is not an enlarged kidney, so this is a small kidney, but it has got a multicystic appearance, and the cysts seem to be both involving region of the cortex as well as the medulla. This is another case where the external surface looks kind of like the Adp Kd1, and the cut surface shows multiple cysts throughout the region of the cortex as well as the medulla. Now this is an interesting scenario where you get the cystic change within the kidney towards one side, whereas the contralateral side shows that the kidney has actually undergone atrophy into a small nubbin. So basically you have the cystic dysplasia on one side, and you have got the contralateral side renal agenesis. So you could actually name this particular thing as adysplasia, the A actually standing for agenesis. So any combination of renal aplasia along with dysplasia will satisfy that particular nomenclature. The importance of noting the dysplasia within this particular context is that there is a higher risk of recurrence in the subsequent births if this particular kind of dysplasia is seen. Otherwise, if there is a non-syndromic dysplasia involving only one kidney, the risk of recurrence is not that much. In fact, it's almost zero. So what are the various clinical presentations? You have the syndromic forms of dysplasias which will present with large diffusely cystic kidneys. I will not go into the detail of all these syndromes because that will take away our thing from the course of the main discussion, but you have got the Vactal association, Prune-Belly syndrome, Meckel-Gruber syndrome, which we have already seen in the context of nephronothesis, Dandy-Walker syndrome, etc. You also have the non-syndromic ones, which include the usual multicystic dysplasia, but the dysplasia could be aplastic as well. It could involve only one segment of the kidney. It can be associated with the urinary tract obstruction. As you see, this particular picture shows the kidney which is misshapen, multicystic, but the underlying ureter is also dilated and abnormal. Many of those dysplastic kidneys will have this kind of presentation. So let's see a virtual slide. So basically, as you see, both the cortex as well as the medulla show a kind of effacement by multiple cysts of varying sizes all over, but then there are some other histologic findings which are kind of peeking out from the background. We'll be concentrating on those first. Okay, but first let's just have a look at those variably sized cysts. As you see, they are lined by the usual tubular lining of slightly cuboidal cells, which can sometimes be very, very flattened. But the interesting thing that is happening is actually in the background, where you get all these very small primitive renal tubules, which I'm not sure whether it can be made out on your mobile phones if you are seeing from there, but there are these collarets. There are these collarets of these spindle cells which seem to be growing in a concentric fashion around these primitive tubules. You can see these collarets happening all around these primitive tubules, concentrically. Is it visible, sir?
Yes, it's visible.
Okay, ma'am. So you have these nice collarets of these primitive spindle cells, many of whom will have a smooth muscle phenotype going around these primitive tubules. These are, otherwise they are kind of bland, these spindle cells. You also have this small amount of hyaline cartilage, which is seen over here towards the 12 o'clock position, which looks slightly like the hyaline cartilage, and you have got the primitive glomeruli as well, which are seen along with the primitive tubules. So basically you have an abnormal architecture where the nephrons are all very, very immature, and you have got a stroma which is very undifferentiated mesenchyme, which is seen to grow around the immature tubules in the form of spindle cell collarets. So if you have ISC, you will see that these particular spindle cells are actually positive for ER and PR. Overall, the architecture is very, very haphazard, disorganized, and you do not get the normal proximal nephron elements. And you get the metaplastic cartilage. Metaplastic cartilage, although it is very striking, may not be seen in all the cases, so that should be kept in mind. And although the changes is mostly diffuse, if you were to see this particular case in a slightly older age group, sometimes the changes might be segmental. So now let's just put all these three particular groups of disorders for the sake of the PGs in a single perspective, because I guess that is one important slide which will help you out at the time of the gross seminars. So basically the main issue which you will be faced with is if you are given a kidney which is large and which is probably in the neonatal age group or probably in the early on. So you have a large kidney which has got a kind of a multicystic appearance. How do you go around segregating the ARPKD from the dysplastic categories? One important thing to be kept in mind is that ARPKD is always diffuse, whereas in the case of dysplasia, although it is often diffuse, it can be sometimes segmental as well. So if you are seeing only a segmental change, think more of a dysplasia. Ureteric abnormalities are not expected in the case of ARPKD, so if you are seeing that, again think of a dysplasia. The reniform shape of the kidney is usually retained in the case of autosomal recessive as well as ADPKD, whereas although often it is maintained in the case of dysplasia, sometimes it can be lost. So if you have an abnormal misshapen thing which is claimed to be the kidney, you know that you are dealing with the dysplasia. The cysts in the case of ARPKD are mostly uniform. As I have said, they are beautiful. They extend all from the medulla towards the cortex and uniformly are seen throughout the kidney, whereas in the case of dysplasia, they are not that much uniformly distributed. And if you are to get the other histories, liver abnormalities sometimes might not be seen if you have a non-syndromic disease in the case of dysplasia, whereas in the case of ARPKD, to some extent, liver will always be abnormal. Now coming on to the category of the glomerulocystic kidney disease, I have kept this towards the end of the discussion because I believe you will probably not be dealing with an entity of glomerulocystic kidney disease straight off as a primary disease. Most often in your clinical practice, what you will be seeing is that there is significant amount of glomerulocystic dilatation, but it is usually secondary and is happening secondary to diseases like ADPKD, ARPKD, tuberous sclerosis, etc. Whereas the primary ones are some of the diseases which are actually we have talked about in the setting of autosomal dominant tubulointerstitial kidney disease, that is the UMOD mutation or the HNF1 beta mutation. So the cysts here, if you are to talk only of the GCKD in isolation, the cysts will be multiple, varying sizes, predominantly cortical, because that is where the glomeruli are, and the glomeruli are enlarged to more than 3 times of normal, and by definition the cysts have to be seen in more than 5% of the glomeruli. So this particular one is actually a case of ADPKD, but you see these large dilated glomeruli which are seen over here. So this is a kind of secondary glomerulocystic kidney change. This is a multicystic dysplastic kidney where you have this primitive hyaline cartilage, this particular metaplastic hyaline cartilage, and you see that there is this dilated glomerulus. That is a kind of a secondary glomerulocystic change. This particular slide has already been seen. So this is a case of ADTKD where because of the HNF1 beta mutation, you have a primary glomerulocystic change happening. This is accompanied by some other glomerular changes where we see that the capillary, instead of forming a small polar loop, is spreading out along the entire course of the glomerulus. So this is known as the duplication and spreading of the glomerular capillary tuft. Now, the main purpose of talking about this particular group of diseases was that most of them are inherited, and now we move on to the category of the acquired cystic kidney disease. So the acquired cystic kidney disease often can look like the inherited ones by the fact that they are often multiple, they are bilateral and lead to chronic renal failure. However, you have not been able to establish any kind of hereditary cystic disease priorly. Majority of these patients are actually those who are put on dialysis, and if you have a patient on dialysis over a period of more than 5 years, chances are that he or she will develop some amount of cystic kidney disease, and many of these cysts are actually prone to develop RCC as well. For example, in this particular picture that we are seeing, you have all these randomly distributed cysts, but then there is a nice tumor also sitting towards the lower pole, which was not talked about as to what particular type of tumor it was, a very well circumscribed one. So the cysts are not very large in size, 0.5 to 2 centimeter, and as far as the histology goes, it's pretty much the same as what we have already seen. The lining is cuboidal to sometimes flattened, sometimes can be focally columnar, and you can sometimes get epithelial hyperplasia as you saw in the case of ADPKD. So this is another case where after sectioning you see that these multiple cysts are present throughout the parenchyma, involving both the cortex and also extending towards the region of the medulla. And if you see the slide, so you have got these large cystic structures which are kind of displaced towards the central location, medullary location, and these cysts are actually lined by a layer of bland cuboidal cells. The more interesting thing is what is happening in the interstitium, because you have the changes of CPN. So chronic pyelonephritis, lot of interstitial inflammation, fibrosis, atrophic tubules, some of which are dilated, along with thyroidization, are all seen in the case of end-stage renal disease, and that is seen in this particular case. So you also have global glomerulosclerotic obsolescence. So there is one entire glomerulus, whereas the rest of the glomeruli are showing sclerosis. And on the left, you are having the atrophic tubules along with these colloid-like droplets. That is thyroidization. Simple cortical cyst is one of the commonest cystic renal lesions seen in the older patients. It can sometimes be multiple large and often are seen to hang out from the surface of the kidney, forming an exophytic mass, exophytic cyst rather. They are usually seen in the elderly age group, but the lining is the same flattened layer of cells, which can sometimes also appear cuboidal. There they do not have the epithelial cells. They are mostly flattened and attenuated, and the calcification can be sometimes seen within the cyst. Localized cystic kidney disease is another condition where you have large number of cysts which can involve both the cortex as well as medulla, but it seems to be localized to a certain region in the sense that sometimes it can also be mistaken as a renal tumor. The contralateral kidney by definition should be non-cystic, and the cysts overall resemble what we see in the case of Adp Kd, but they usually only partially involve the kidney and are lined by low cuboidal to flattened epithelium. So, as for example, in this particular case, you have this conglomeration of cysts in a particular segment. The rest of the cyst, the rest of the kidney is showing a lot of tubulointerstitial inflammation along with some amount of tubular atrophy, while the cyst is basically lined by a very thin, kind of attenuated to slightly low cuboidal kind of lining. Medullary sponge kidney. So, medullary sponge kidney is basically, as far as the inheritance is concerned, there is no uniform consensus, although the current literature seems to say that there seems to be an autosomal dominant inheritance pattern to this particular disease. The most important change that we see over here is that the cystic change is seen to involve the renal medulla, especially in the region of the renal papillae, in the region of the medullary pyramids, and these particular cysts are prone to get deposits of calcification, that is calcific deposits within them, giving rise to a high incidence of nephrocalcinosis along with nephrolithiasis. So basically, many of these cysts will never come to come to the pathologist unless the patient presents with a urinary calculus, and sometimes many of these cases will be even silent. So, and the kidney may not be enlarged as well. The most important change is seen in the region of the collecting ducts, where you have a cystic dilatation of these collecting ducts within the region of the pyramids, and the lining is again by cuboidal or flattened epithelium, and you get these calcifications within these dilated, elongated columnar collecting ducts. So, for example, if you see this particular kidney, you are seeing that these cystic structures are again mostly localized towards the region of the medulla, although there is a bit of corticomedullary presentation as well. So there could be a little bit of overlap with those entities of ADT, KD, etc. that we have talked about. And I could not get a slide for this particular thing, but this particular picture which has been taken from this book shows, I think it's a whole mount picture. So you have these elongated collecting ducts which are mostly towards the region of the renal pyramids as these elongated circular structures, and within them you are getting these calcifications which are so characteristic of this particular disorder. In the last two categories are actually they are basically non-neoplastic renal cysts, but they are seen in association with the tumor syndromes. But because they are non-neoplastic, I have included these particular two categories within today's discussion. The first one is the tuberous sclerosis complex. As we already know, it is an autosomal dominant inheritance of mutations in the TSC1 and TSC2 genes which encode for hamartine and tuberin. Now, one interesting tidbit about this particular mutation is that the PKD1 locus of Adp Kd is situated very close to the TSC2 gene. So basically, if you have a large scale deletion of this particular gene, you can have a wiping off of the entire PKD locus along with the TSC2 locus, resulting in not only Adp Kd but also TSC at the same time. As far as the phenotype goes, we already know there are these fibromas over the face, ungual fibromas, you have these macules over the skin. Angiomyolipoma is one of the most important renal tumors that you get in this particular condition. You also have subependymal giant cell astrocytoma, you have retinal hamartomas, cardiac rhabdomyomas, etc. But as far as the cystic change is concerned, one of the minor changes is that you get multiple non-neoplastic cysts in the kidney. And the cysts here are classic because unlike the prior cysts of the tubules where we had seen that the lining is atrophic to slightly low cuboidal, here they are lined by cells with a deeply eosinophilic cytoplasm, as we will see subsequently. So this is a cystic liver which is basically this is a particular cystic kidney from a case of tuberous sclerosis where you see these multiple cysts all over, and then you have this angiomyolipoma also towards one corner of the kidney. And the cysts are seen to be lined by cells with deeply eosinophilic cytoplasm. As I have already said, many of these kidneys will actually come to you not because of the cyst, but because the patient has had an AML or sometimes, uncommonly, even RCCs. So towards the left, you have got this RCC element which is seen over here, and over here you are seeing the AML component. You have got the fat and you have got the spindle cells, smooth muscle cells, and also the particular vasculature from this spindle cells are actually striking out. The last category of the discussion is again another syndrome, which is the von Hip and Lindow Syndrome. Here the cysts could be non-neoplastic, but they could be neoplastic as well. So that's one important thing to keep in mind. The most important genetic basis is that you have a tumor suppressor mutation of the VHL gene on the chromosome 3p. You have bilateral multiple renal cysts and RCCs. So the multiple renal cysts is what we are actually concerned with. How do the cysts look? So these particular cysts are actually lined by very clear cells. However, depending on the number of the cells which will line this particular cyst, you can actually typify this cyst. So you have benign cysts where the lining is only of one layer of single clear cells. Those which are lined by 2 to 3 cells, which are designated as atypical cysts. So as you see in this particular picture, the number of the clear cells lining this cyst has actually increased. So that is suspicious. And if you have proliferations of more than 3 cells thick, you are actually dealing with a cystic renal cell carcinoma, which is pretty common in this particular group of patients. So as this particular picture shows, there is an exuberant thickening of this lining of the cyst, multiple layers of these clear cells lining the cyst wall. So this is basically a cystic renal cell carcinoma which has happened in a VHL syndrome. And this is why you will need to screen these particular patients after age 8 by annual USG or MRI of the abdomen. I think we are done with today's discussion because we have kind of covered most of the non-neoplastic entities. I think sir can take it on from here.
Yes, absolutely right. I think we will break up it into 2 sessions. That would be best. Wonderful presentation, Mitadru.
Thank you.
Very lucid, very clear in your mind what you were talking. Really taken a lot of effort in trying to put all this together. A fantastic compilation, right from the book, comparing the book to comparing the various cysts anatomically, microscopically, genetically, and prognostically. Fantastically done. Wonderful presentation. Excellent. I think one of the best presentations I've seen for anybody talking on the cystic diseases, dysplastic lesions of kidney.
So in this respect, I just interrupt. This particular presentation is actually a bit of a deja vu for me because in the year 2008, it was given to me as a short topic presentation. But at that time, I actually fumbled up the thing big time, and my presentation had to go into a 2.5 hour thing. Many of us missed our lunch on the day. So there was a competition going on.
So the short case became a very, very long case. But wonderful presentation. Very, very nicely done. Excellent. We will really be looking forward to the second part of it, which will be the neoplastic part of it.
Nadeem, can I just...
Yes, always, please.
Wonderful presentation.
Thank you, ma'am.
I just wanted to ask, how often do you see cases of nephronephrosis?
Ma'am, I couldn't catch
How
you.
often do you see cases of nephronephrosis?
Yes, ma'am. Actually, if I am to talk about NPHP as well as the ADT Kd category, I personally now think I might have seen quite a few and I might not have actually known about those particular things because I have seen quite a few cases where we just used to label it off as a tubulointerstitial disease during the course of my career and really not think too much about it. And the history is that of a slightly young male, probably 35 or 40s. So I guess a few of them might have been those.
Okay, and the other thing I wanted to ask was Motile Cilia. Like we do a lot of pediatric autopsies in PGI, so I've seen a lot of cases of Motile Cilia syndrome wherein you have bilateral multicystic dysplastic kidneys, ductal plate malformation, polydactyly, and also any kind of a brain malformation. So this is a basically tetrad. But I've never come across any child or any fetus with nephronephrosis.
No, ma'am.
It shows bilateral multicystic dysplastic kidneys, and the kidneys are enlarged, they are symmetrically enlarged, they maintain the reniform shape, and they have multiple cysts on the surface as well as on cut section they have rounded cysts all over. But I've
Okay.
never seen any case of McGruber associated with nephronothesis.
Okay,
I,
ma'am.
I really don't know if this kind of an association actually exists. I didn't know till date. And the
Okay,
other
ma'am.
thing is the primitive ducts. They are the pathognomic features of dysplasia. So without
Yes.
the presence of primitive duct, we cannot call something dysplastic. So this is
Right.
what the students should understand.
Right.
That's another important thing. And the other
Right.
thing is that in autosomal recessive polycystic kidney disease, 100% cases have ductal plate malformation.
Yes.
Actually, ARPKD and CHF, they are two ends of the same spectrum.
Yes,
And
ma'am.
we have the perinatal variety, neonatal variety, infantile variety, and the childhood variety. So as
Yes.
you go towards the childhood variety, the cysts decrease in size, but the
Yes, ma'am.
liver, in the involvement of the liver increases. So
Yes,
that's
ma'am.
how it happens. Yeah. Of course, you explained that, but this is just for the postgraduates.
Yes,
Thank you very
ma'am.
much.
Thank you, ma'am.
Thank you, Dr. Nandita Kakkar. Dr. Nandita Kakkar is an international expert on pediatric pathology. She's wrote a fantastic book on autopsies. I think we all should, and she has gifted me one of that copy. Thank you so much for being here on this platform and sharing your experience. Thank you,
Thank you
Dr.
so much.
Nandita. So nice of you to be here.
Thanks, thanks.
Yeah.
You're doing a wonderful job, Nadeem. I
Thank
must
you.
say so. Although live, I've joined after a long time, but then, of course, I see it on a Sunday, sit comfortably and see it on the YouTube.
Right.
Yeah, thank you
Right.
so much.
Thank you.
Thank you, Dr. Mitadru.
Thank you, Dr. Mitadru. Wonderful presentation. We will surely get in touch with you for the second session and we'll fix it up. Right.
Sure,
Take
sir.
care. Please share
Sure,
the
sir. Bye.
PDF of this part,
Sure,
and
sir.
then we will share the PDF of the second part subsequently.
Sure, sir.
Right. Take care.
Bye, sir.
Good night, everybody. Good night, Dr. Kakkar. Thank you so much. Bye bye. Take care. Bye.